meniscal hollow or autograft is a challenge. And I thank Dr. Dharmpal for preceding my talk and making things clear of where we stand with allo or autograft. My charge today, as discussed with Dr. Sharath, was to give some indications and some contraindications about when we do your allo or autograft, and what are the limitations. Who are the person who traveled the moon first in this space? So if you look at this, all starts when Fairbank first told us that when you inadvertently remove your meniscus, those days, it will cause you an osteoarthritis. And that was very true nowadays. And that is when we started realizing with the campaigns which all the big companies started saying, save your meniscus. The Save Your Meniscus campaign is because we need to have the life of your knee for a longer period of time. The first gentleman who started doing this was Lockie and his team, who really did with a proximal total allograft with the meniscus in place. Khan was a gentleman who really had a massive, you can say, a list of surgery follow-ups, wherein he did 20 cases with the quadriceps tendon. And we can call him as a pioneer of who pushed the limits to do arthroscopic transplant in meniscus. We all know that the key structure for the knee is the meniscus. It gives us life and what are its function. But what we need to know nowadays is what happens when the knee becomes deficient with the meniscus, and where do we head when the meniscus is not there in the knee. The biomechanical changes, the micro motion instabilities that are there in the knee will cause a lifeline of the knee to reduce, and everybody nowadays wants to be active and on their toes. They need a knee to function well. So yes, preserve your knee for a longer period of time. That will be the basic goal of managing your knee. If you know who are the patients we need to select that need to undergo a meniscal transplant, of course the meniscus should be absent, and you should be a young guy who has got a knee which is in functional capacity without much of malalignment in the knee. And I urge all the august audience who are present here to read this manual by Dr. Lob Rapport and his team. And it is they who have really pioneered in the earlier stages when everything was dark and gray, saying that, yes, this is the line you have to travel, and then do a process called as the meniscus hollow or autograft. So kindly get hold of this copy of book and then read through it. There are a few salient indications that have been given in this book and also by the Association of Experts who are really laid down the guidelines for how a meniscus transplant has to be done. Out of the few that are mentioned in the book, it is unicompartmental pain the patient should have. Of course, meniscus should be not there. Age of the patient, they say it is less than 50 years. But if I look at only the age as a criteria, we would not be right in choosing in that way, because there are many other things that you need to look at when you try to do a meniscal transplant. For me, the most important thing that I look at is the alignment of the limb and the cartilage that we see when we put the scope. If I find the cartilage is as smooth as my bald head, I am in for a meniscal transplant. If my bald head has got some ragged surfaces, then I do think about whether this gentleman really benefit with a meniscal transplant or not. The indications will also come with some contraindication that we should be aware of. If the patient is asymptomatic, but you see a knee where there is no meniscus, so you need to know why the patient has come to you and choose your indications appropriately. Yes, if the wear and tear in the knee is not much or it is too much, then yes, that becomes a contraindication. Apart from that, inflammatory arthritis and general contraindication for a knee procedures are the contraindications for knee transplant of a meniscus. Graft preparation, what are the kind of graft that you have to choose? You should be knowing. Fresh frozen graft or a freeze-dried graft. fresh frozen has a time limit. You need to do within this many hours. So yes, if that is a situation where you are working, or if you are working in a center where that is freely available, that would be the ideal thing to do. But the success rate and the downside of it, everybody should be knowing. And that is what dictates when you use a freeze-dried graft. Because we are living in a situation wherein don't have access to all of those. Few of us have tried to venture and tried doing an autograft, which is feasible for our patients, both for the purse as well as the way we do these kind of procedures. The graft sizing has to be followed basically by two methods, a radiological method as well as by assessing with CT scans. The radiological methods have been earlier described by Pollard and his team, where they do various kind of X-ray imaging. Both the lateral and the medial compartments are measured. Okay, and based on the percentage of length of the tibial condyle as well as the medial side as the lateral side of the tibial condyle, the assessments of the meniscus can be made and chosen appropriately. Yes, nevertheless, you do your scopy assessment appropriately and then plan your surgeries in a way that is to be done. Now to come to the techniques, there are various ways to skin a cat. On the medial side, preferably, the literature has shown that you can do both with the all soft tissue part of the meniscus allograft or a meniscus allograft with the bone plug. Both will give great results. And on the lateral side, generally, because there is a chance that the results may go down, they want to go on the safer side and try to create a trough for the bone plug that go and sit and then give you a good coverage. We have seen our good colleague, Dr. Dharnpal, very nicely demonstrating just a peroneus graft for the lateral meniscus. You can do in such a fashion also. But these are the literature studies that are available. You should be reading this and then know how these results of whether using only a soft tissue part or only a ends of the meniscus with bone plugs give results. Now, when we do these kind of procedures, we should be also mindful of reading what the outcomes are of these procedure. Any new procedure in the market, we should not be happy to go and put our hands on. Sometimes they are too hot. You will get your hands burned and then you'll cut a sorry figure in front of a patient. One bad patient in your clinical practice will land you in trouble. So kindly work with people who are doing or having this experience of doing this, or attend those kind of cadaver courses or do some saw bone model studies and then try to practice these kind of procedures. The transplant that survives longer is probably on the medial side. You can see that it survives when you do a meniscal transplant. The life can increase of the knee by 8 years. And I'm sure when your knee survives for 8 years, there is many things that you can do, not only by hopping shops, but you can hop many other places as well. Lateral meniscus has got a little lesser life. It is around 7.5 years. That is good enough. And you can see that the patient outcomes, whether you do lateral meniscus or a medial meniscus, allo or autograft, the lifespan is good and patient does have a better outcome. He is thankful in the end for what you have done. But mindful of all the reoperation rates that are associated with any kind of procedure. Even this procedure has reoperation rates, so it is not foolproof. So when your patient comes to your clinic, you sit him down, talk to his near and dear ones, because there are many things that are associated when a graft is being put. The first thing that can happen is the body can reject it. So you should be telling him all the things in black and white. You cannot hide anything when you talk about a transplant to a patient. Rehab is a standard protocol you follow for all the rehab procedures, but the main aim or the goal for you would be to get by 6 weeks a 90-degree range of motion. Weight bearing is always guarded, and then you should have a good rehab team as you need for any procedure that you do on a knee, because as I say always in my lectures, your role in any arthroscopy surgery procedures of the knee is only 50%. You need not boast about what you are doing. The next 25 depends on the patient, and the another 25 depends on the physio that rehabilitates the patient. So having said that, there is always a downside for these things. So you should be very clear in what you are doing with the patient. Autologous grafts have also got the same indications as the allograft, but the advantage is it is less costly on the purse. We can titrate the size of the graft as required because it is a soft tissue graft. We can titrate the length of the graft as we required when um, we are being we are drilling a tunnel so that we can accommodate the extra length of the soft tissue in the tunnel. When we are doing an allograft, it comes as a pre-designed package. So you have a very little margin of error for you to do these kind of procedures. Whereas with these grafts, you are used to harvesting a semity, you are used to harvesting a peroneus longus, you are also used to harvesting a gracilis. So all those are well known to you. So only thing is you have to just deviate from the near normal that you are doing and accommodate those skills that you have developed already doing a meniscal repair or a ACL reconstruction or a root repair to advance and do a procedure which is called as a transplant. ESCA has clearly come out with guidelines and they have shown that great results can be expected with these kind of procedures. But the earlier papers that have come out with these, especially with Khan and his team, has come out with mixed results. So this is a pioneer who really did the first transplant with the use of quadriceps tendon. This is another paper by Lanny Johnson and John Fusion. There are other groups which are from the American and the Canadian-based group, which did lateral meniscus transplant. But if you see how the patients were chosen for a transplant, there are the indications which are, not of great support for the procedures that we do. So yes, when we read a paper or when we try to do a procedure or read through what a gentleman or a lady has done, you need to see the small print, like what we say in म्यूचुअल फंड सभी के लिए सही है but in the end he says दस्तावेज के अधीन है, meaning the small prints tell about the loopholes in a procedure. Okay, this is gentleman whom we are working with frequently and we are in touch with them to know how a meniscal allograft or autograft does, and these are the people who have got a long-term result of how the meniscal allograft with the semitendinous is. They have reported great results in the literature, and we are also in the follow-up of our patients, trying to match what people in the world are doing and trying to learn from them, and hope our results in the coming days also will be matching to these guys who have come out with wonderful results, which is economically viable for the patients of our country. Yes, when we do such a procedure, we always want to know, भैया ये natural knee जैसा हो सकता है? This is the word the patient will ask to you when he comes to your clinic. என்னப்பா இப்படி நல்லா இருக்குதா, அப்புறம் ஆபரேஷன் அப்புறம்? So all this he will ask, wanting you to tell whether there is a 100% guarantee, whether the load bearing will be guaranteed. So yes, there are studies that have come out and trying to say that yes, the middle compartment pressures are equally normal like the lateral compartment, and the pressure studies done after doing allograft transplant or the autograft transplant are giving great results. So yes, science is advancing, we need to catch up, but yes, catch up slowly. The tortoise and the hare story should be remembered. Don't be in a hurry, have patience to graduate yourself to doing these kind of procedures. This is an example I would like to illustrate. A young gentleman who is 39-year-old school teacher who waited as long as 20 years to get his ACL reconstruction done. When he came to our hospital, he has definitely a loss of meniscus which he had. There is grade 3 pivot shift and all those things. We counseled the patient. Yeah, we counseled the patient for ACL surgery. And then in the primary case, we did an ACL reconstruction because the cost of the surgery is huge for an allograft as well as for an autograft. We sat the patient down along with his relatives. He's got a young family. Okay. So he said, I'll come back for the procedure second time. So when he came back, alignment x-rays was done. And this is the pre-op x-ray. His range of motion was great. And these are the images to show that there is a near total absence of the medial meniscus. Though he had also on the other leg, the medial meniscus absence. We are going to show you only the full meniscus that we did on this side. So this is how the images will be taken. You read through the images. You already done your scopy. You know how the cartilage is inside. So when you go, this is what you will see, a grade 3 outer bridge cartilage lesion. But if you can see the femoral condyle was good looking. And that is when you make your choice. A 70-year-old gentleman or a young gentleman with a good cartilage, both are same. So you need to give them good life with their knee when they are, involved, when they are involved in sport, when they are active, they want to live by themselves. So we chose a meniscal allograft using semi-T, and we stitched periosteum at the ends of the meniscus. And this is how it looks once you finish your meniscus autograft. If you see, tunnels are drilled for the meniscus root repair, both in the posterior side for the posterior root and anterior side in front of the anterior flare of the tibia. And you will require many sutures, as Dharnpal was telling, to secure your meniscus. The most important thing is a centralizing suture, which will drag your meniscus into the knee. And that is like the lighthouse, which takes the path for the meniscus to go inside the joint. So this is the 3-month follow-up of our X-ray. If you can see, and if you want to critically assess what happened to this patient, you will always see that the meniscus will be extruded in the joint. That is quite natural. Extrusion of the meniscus is natural when you are 3 months old. But a longer follow-up, say it is 1 year or 2 years follow-up, will be advisable for anybody to see these kind of patients. However, the patient is doing very well. His range of motion of the knee is good. And subsequent follow-up of these patients will be sharing with you as and when the scientific forum allows us to present. And a humble request for all of you gathered here. I will be contesting for the IAS Vice President elections in the coming year. If you are free about, all the politics that is going around, and if you want a chance for a person to be given other than the state that is already got a representation, kindly choose Dr. Rajkumar as the Vice President of the Indian Arthroscopy Society, and I will be greatly obliged when you do so. Thank you so much.